These are my disclosures, none are relevant to this talk. So I first want to start with looking at the regulatory pathway for a lot of these biologics. And so these are primarily regulated by the FDA through the Center for Biologics and Research. The challenge is a lot of them are subject to the human cell and tissue protocol, and there's no pre-market review needed if they're minimally manipulated. That means if the tissue is used for its intended purpose or minimal manipulation of the cells, it doesn't alter their biologic properties. And so a lot of these materials really do not go through heavy scrutiny because they're just viewed as human cells and tissues. If they don't fall into that, then they are regulated as a drug device, biologic, or combination product. And so that's true for growth factors like BMP2 as well as DBMs. So there's been a lot of challenges with stem cell clinics over the years. Traditionally, these are typically international, but as of 2017, there are 432 businesses operating over 700 clinics, primarily in California, Florida, Texas, Arizona, and Colorado, which had looser state regulations. They were usually sourced from bone marrow, adipose tissue, and usually marketed towards musculoskeletal conditions that didn't really have clear and effective treatments, such as back and neck pain, arthritis, or cartilage defects, and a lot of misleading marketing and terminology used. So really first just want to look at what is a stem cell. So there's various different types of stem cells. So totipotent cell is really found in the developing embryo where it can form any cell type or extra embryonic tissue. Pluripotent cells are embryonic stem cells, or iPSCs, which are induced pluripotential stem cells from regular cells. And these can give rise to any of the cells in the body. And then multipotent cells are what we typically think of as mesenchymal stem cells, where they can give rise to a number of specific cell types. Usually it's viewed as cartilage, bone, or fat cells. And then a nullipotent cell is kind of an end cell that just forms the tissue. And so the International Society for Cell and Gene Therapy has specific criteria to identify a stem cell. So these have to be culture expanded, adherence to tissue culture plastic under standard conditions, phenotype positive for specific markers of the end cell types, and then phenotype negative for a lot of things like hematopoietic stem cell markers, and then in vitro differentiation to the 3 cell lines, so bone, cartilage, and fat. The challenge is a lot of mesenchymal stem cells are very rare in connective tissue, usually about 1 in 20,000 of the cells that are in there, and most cells are really just progenitor cells. And so a lot of freshly isolated cells that people use in these stem cell clinics are not actually stem cells, and really probably 1 in 20,000 of them are. And so again, they need to be culture expanded, show that trilineage potential, and have defined surface markers. And so what are stem cells doing once they're injected? So that's somewhat unclear. There's probably some sort of paracrine effect where they produce cytokines and mediators that can affect the local tissue environment. This was a study that we did several years ago looking at luciferase tagged stem cells that were injected into mice. And really by about 4 and especially by 8 weeks, there was a significant reduction almost back to baseline of the stem cells. So a lot of them die off, but maybe there's some cell signaling in between. A lot of stem cells are used in spinal fusion for osteoinduction and osteogenesis. But in many animal studies, they're usually combined with cell and other gene therapy, different growth factors, and various scaffolds. And these wouldn't meet the FDA criteria for minimal manipulation and then would need further human study. Most of the human studies out there for fusion are focused on bone marrow concentrate or aspirate. And again, it's probably 0.01 to 0.02% of the cells in there are actual stem cells. And there's also cellular allografts that have been used, which have some sort of proprietary formulations, but are regulated as standard human cells. This was a great paper from Zori Busser from several years ago looking at different DBM formulations with and without cells, and found that there really was no benefit to having the cells included, probably because a lot of them die off fairly quickly. In degenerative disc disease, any sort of biologic treatment with cells is very challenging because it's avascular and hypoxic, and there are a lot of challenges with cartilage differentiation under these conditions. And the nucleus pulposus is relatively similar to articular cartilage. There are some animal studies showing benefit, but very limited human data, again, because most of these cells are considered minimally manipulated and don't undergo further study, and there's no control arm. So Discgenics has probably gone about this the right way, looking at nucleus pulposus-derived stem cells. So they take nucleus pulposus disc tissue and digest it with collagenase and then expand the cells using a proprietary cocktail in 3D culture, and then again confirm the trilineage potential for stem cells. And then they used a disc degeneration annular punctural model in rabbits with 75,000 cells. And on their histology, the dark orange and bright blue show proteoglycans, which are what causes the hydration of the disc. And so you can see in the healthy control, there's very good hydration, not in the sham and vehicles, but in the three different donor groups, they all had fairly robust regeneration of that. In their phase 1 and 2 trial, they looked at a low dose versus high dose cell delivery and found that there was a significant reduction in ODI as well as VAS, and then a significant improvement in the disc volume for the high cell delivery. There's also been a lot of use of stem cells in spinal cord injury with either intrathecal delivery or delivery right at the site. Other types of stem cells have been used in addition to mesenchymal stem cells, such as from Schwann or olfactory and sheathing cells, but I think there's still work to be done in this area. Moving on to platelet-rich plasma, so if you look all over the internet, there's tons of advertisements for this, both for spinal conditions as well as musculoskeletal. This is just one I pulled and blocked out who was posting it. But these procedures are offered as cash pay only since it's not covered by insurance. And when they highlight the potential benefits, it's that patients on average report more than 50% improvement in 6 weeks and up to 100% in 12 weeks. I'm not sure we really have any treatments in spine that offer 100% improvement at 12 weeks. But how PRP is derived is you take venous blood and then centrifuge it down through multiple cycles to obtain a platelet-rich layer. That's then activated with various formulations such as collagen type 1, but typically calcium chloride and thrombin are used. And this causes the platelets to release all of their contents and forms this platelet gel with the thrombogenic factors as well as various growth factors that they release. And so this is looking at a lot of the different growth factors that are contained. So a lot of these are things like IGF-1, which can enhance a lot of bone and cartilage synthesis, platelet-derived growth factor, VEGF, and TGF-beta superfamily, which both affect bone and cartilage regeneration as well as disc tissue. Interestingly, they contain very little of BMP2, which we use in a lot of our fusions. Unfortunately, there's very little human evidence that there's any benefit to PRP in enhancing spine for either degenerative pathology or for fusion. There is more evidence probably for joints and tendon and ligament reconstruction, although that's somewhat limited as well. In terms of specific growth factors, so BMPs are the ones we most commonly use in spine, and they're part of the TGF-beta superfamily. There are multiple BMPs, but the ones that are approved for use are BMP2, which is used very commonly, and then BMP7, which was approved through a humanitarian device exception and isn't really used much clinically. But these are primarily used to contribute to bone formation, although BMP2 at low oxygen concentration actually is a very robust signaling molecule for cartilage regeneration. And so it has a lot of uses both in the inflammatory and endochondral bone formation stages, along with many other growth factors, but really the BMPs have been the most widely explored in human use. So finally, moving on to exosomes. So these were actually discovered in the 80s and are more a way for cells to get rid of their initially viewed as kind of getting rid of their garbage, but they're actually viewed now as more of a cell signaling pathway. And so these often contain messenger RNA or microRNA, which affects protein synthesis and other small proteins as well. They're taken up by additional cells, and then again, protein synthesis is usually derived. And so these can be obtained from various different stem cells, naive stem cells, Schwann, and microglia, and these have been used recently in spinal cord injury. And then for disc regeneration, people have used nucleus pulposus as well as annular fibrosis exosomes that are then delivered to try and deliver some of these mRNAs or microRNAs that can affect signaling pathways or decrease inflammation, such as the metalloproteinase pathways. So in conclusion, there's some promise to regenerative therapies for disc degeneration, spinal cord injury, and spinal fusion, but still a lot of work to be done in that area. There are significant limitations in the available literature, and really the problem is a lot of these are still viewed as minimal manipulation for human use, and so they're not getting scrutinized the way they should. And so hopefully there'll be more companies pursuing more controlled and FDA-regulated testing to get more of these devices and biologics in the market. But until that time, I would really maintain a healthy skepticism when you're viewing these devices and biologics. Thank you.
We are constantly looking for ways to promote health and disease, but the natural history is that we degenerate our diseases until they're kaput. Have you come across any biologics that are intended to accelerate what happens intrinsically to the disc over time?
You mean to accelerate the degeneration?
Get it over with.
Well, I mean, that's all, any of the pro-inflammatory cytokines will do that. And so a lot of these devices are designed to kind of block those inflammatory pathways. But there are certainly things, any of these degeneration models where you can induce inflammation either with trauma or some sort of collagenase or other inflammatory injection.
All right.
What do you think would happen to utilization if we got Medicare rates and not out-of-network cash rates?
Well, but to do that, there's a lot of testing. So I think if you can show that these are actually effective, then this would be a great devices to be.
I mean, just today,
so
you get $50 instead of $5,000.
Right, I think they would disappear quickly. So when it's $5,000-$10,000, people are happy to do it, and anything sounds better than getting a fusion or any sort of open or minimally invasive surgery.
Yeah. Great job, Ben. That was excellent.
Thank you.